Hello, I'm Dr. Dudley Harris. You may know me. I'm the medical director for professional vision care. A year or so ago, it occurred to me that the form that the optometrists use to report their findings to the family doctor could be improved. And I set out to make some improvements. And I've been working with Dr. Vivian Ayub of MCCI to come up with a form that's easy for you to use and easy for the family doctor to understand. And we've come up with this form, which you're going to be seeing and using in the near future. The family doctor wants to know, can his patient see okay? And the very first question on the form is, can the patient see 20/40 or better? So right there, that's most of the information that the family doctor wants to know. But there are other things that certainly are important. In addition to telling the family doctor what the vision is and about medical problems, we want this form to show that you've done two things. One, that you've screened for glaucoma, and two, that if the patient's diabetic, you have screened for diabetic retinopathy. This is covered on the form and in a very easy to read manner. The second part of the form deals with glaucoma screening. Now, you and I know that just measuring the pressure is not sufficient to screen for glaucoma. You also have to take a history and look at the disc. But for the purposes of this examination, all you have to do is check the pressure. So you check the pressure, it's 21 or below, and you say, screening done, no glaucoma suspected. Very simple. If the pressure is over, say, 22, then you may want to take a look at the disc, or you may just want to refer, because that would be perfectly legitimate just to refer that patient. You don't have to worry with the patient anymore. The third section of the form deals with looking at the retina. For the purposes of our examination and this form, the only retinas you have to look at are those in patients who have diabetes. So every diabetic patient needs a dilated eye exam. And just as an aside, I used to think that you just use the slit lamp indirect, you could look through an undilated pupil and screen for diabetes. But I did a screening recently for diabetic retinopathy, and I can assure you that after sweating bullets for a few minutes, I said, give me those drops, because I couldn't see without dilating the pupil. There's just no way. So I learned from that. So you have a diabetic patient, you dilate the pupils, you take a look, and then you check. You did the examination. Check yes. Then, is there retinopathy present? And that's easy, yes or no. And then you have the option of grading that retinopathy. Is it just a few microaneurysms? Are there a lot of dot and blot hemorrhages? Is there exudate? Then you can grade that mild, moderate, or severe. So mild would be a couple of microaneurysms, moderate would be some hemorrhages, severe would be a lot of exudate, edema of the macula and so forth, or even proliferative retinopathy. So then that tells the family doctor the patient has been screened and has no retinopathy, or has retinopathy that is mild, moderate, or severe. So that really tells the family doctor what they need to know about the patient. But in order to be complete with the examination or with the reporting, there are further options. If a patient is diabetic, then you can look at the next section and see that for a patient with diabetic damage to the eyes, then there's some other choices that you can fill out or that you can check. For example, one would be a diabetic cataract, and that's also called a sorbitol cataract or a sunflower cataract. That's a cataract that's seen in young people. It's due to sugar metabolism problems, and it often progresses very rapidly into mature cataract. I don't know that I've ever seen a sorbitol cataract in my practice. It's extremely rare, but if you see one, you've got a place to check. And then glaucoma, of course, can be caused by diabetic retinopathy because the neovascularization in the retina causes neovascularization in the angle, which closes the angle, which raises the pressure. So that would be glaucoma secondary to diabetic damage. So that's a specific kind of glaucoma. You would only check that if there were neovascular glaucoma. When you look through the form, you'll see that there are many choices that you can fill out if the patient has damage to the eyes from diabetes. Most of these are quite unusual, but the space is there for you to fill in if you see like macular edema and so forth. Of course, if the patient has macular edema, you're not going to want to follow that patient. You're going to want to ship them out right away. And so they're off to ophthalmology, and then it's our job to fill in the form, which is then reported in the claims so that Humana picks it up, and then they can also, then they have that way to see that the patient has severe damage. Because the whole point of this is that for a diabetic who has these severe complications like glaucoma from diabetes or proliferative retinopathy or blindness, then the Medicare or CMS allows more payment to the doctor for taking care of those patients because they're sicker. So you can see how important it is that all of this information be given to the family doctor and to Humana. Now, the last part is, what do you recommend? Well, a yearly exam. Do you want to send them to ophthalmology? And if you want to send them to ophthalmology, what for? Do they have a cataract, for example? Do they have whatever you find that you may want to send them for, blepharochalasis or whatever, then that's where you write that in. Now, the last part is comments. And in the comments, it's a place for you to put the things that you pick up in the examination that would affect the patient's care from his family doctor. For example, let's say you find the vision is 20/40 minus or 20/60, and you find some cataract. Then you're going to say in your comments, I found cataract in this patient that I think may be causing some loss of vision. You want to give us ophthalmologists a little wiggle room. If you say, oh, this patient's got a cataract, then everybody gets excited. It may be that the patient doesn't need cataract surgery. In fact, a cataract patient in our office, the way we evaluate that cataract is we ask the patient, how are you getting along with your vision? And we let them tell us if they're having a problem with the way they see or not. And as you know, some people will have a lot of trouble at 20/40, and other people will have no trouble. So we don't operate unless the patient has a problem, or the way we say it is a problem with their ADL or with the activities of daily living. They've got to give us a complaint about ADL in order to justify doing a cataract operation. And furthermore, as you know, the PVC Humana MCCI network is all capitated. So nobody makes any money by doing something. Of course, you may say, well, you make money by doing nothing. Well, true, but we want to keep everybody happy. So we want to take care of the patient. It's just that we have no incentive to sell them an operation. So we don't want to see a patient who comes in thinking they've got a serious problem, and then we have to spend a lot of time telling them that it's not so bad. So you have to be a little nuanced in how you report out cataracts. But there's plenty of room for you to take care of the patient. That's what we all want to do. Just take care of the patient, make them see as good as possible, and we all want the same thing in that regard. Then write your name, sign it, and out it goes. So this form is going to get faxed, and it will get reported to the family doctor. This form is going to go in the patient's chart. From time to time, there will be reviewers who will go out and look at the PCP's chart, and they'll find your form, check off that box, everything's golden. So that's what the new form is about. It's a little background, maybe more information than you wanted to know, but I think it's important that we're all reading from the same page here, and I appreciate the time you've given me to listen to this speech today.